Great. So let's get started. I will continue to admit people as they are coming in. But good morning, everybody. Thank you very much for being here. This is our first of 4 webinars related to the report that DRJ just released called Person First, an investigation and legal analysis of people with intellectual and developmental disabilities in New Jersey nursing homes. So to just go over a little bit of housekeeping to start. So this webinar is being recorded. There is also a transcription available for anybody that would like to have that. Please make sure that you are muted throughout the webinar. I would ask that everybody please hold any questions until the end, but please feel free to put any questions in the chat and we will get to as many as we can as possible at the end. So our first of these 4 webinar series is going to be conducted by our executive director, Gwen Orlowski. And we do, like I said, we have 3 other webinars that we're going to have throughout the month of October, and we will provide additional information about those at the end of today's presentation. So I will let Gwen take it away.
Great. Thank you, Bren. Much appreciated. Welcome, everyone. We have about an hour together this morning, and I'm going to talk at a high level about our report with some detail. And then I really want to hear questions from you, which, as Bren said, you can drop in the chat box all along, and then we'll get to the questions at the end. We want to leave a lot of time. I hope not to talk too long about the questions. And I think it's important to know that this is really to give you a sense of the entirety of the report, which is with endnotes 100 pages long. But that's why we're also having 3 more webinars where we're going to discuss more in depth each of the 3 findings and recommendations, as well as sort of how we did the investigation. So to a certain extent, this one is a little bit of a tease to whet your appetite for those other 3, but please feel free to ask questions about anything you'd like to ask a question about. So I just have to say at the front end, just a huge thank you to the New Jersey Council on Developmental Disabilities for their vision and financial support of this project. It truly made it possible. They were also wonderful partners sharing their expertise and editing and also connecting with us, with people in the community to talk to about this report. There's a little language here, since their funding comes through ACL, that acknowledges the wonderful generosity of the Administration on Community Living that supports this kind of work. And finally, I just want to begin
Gwen, you're muted. I'm sorry. I think I did that by accident. I apologize.
Have I been muted for long?
No, just 10 seconds.
Okay, so again, I'd like to just take a few seconds to remember our dear friend and Bev Roberts, who was such a fierce advocate and really asked some of the initial questions that led to this report back in 2018 and 2019. So if we could just take like 10 seconds of silence to hold Bev in our hearts and thank her for her years of advocacy. Thank you, Bren. Next slide, please. So I'm hoping many of you have already had a chance to kind of poke around the report that's on our website. It's on a pop-up page right now. But the report is dense. There's no doubt about it. And this is just a really high-level overview of the report, the sections of the report. We have an introduction and executive summary. We have a section that really details our investigation, 3 sections going through each of our key findings in very extensive detail, and then our recommendations and conclusions at the end. I also want to mention that at the very beginning, we have a letter to Commissioner Edelman from the Department of Human Services and Acting Commissioner Bastian from the Department of Health. And I think that letter is worth a read also, in part because we really could not have done this work without the cooperation of the Department of Health. I don't think anything in here is a secret to them, because they were the ones we were talking to for a good 2 years or so, even before we launched the formal investigation about our concerns. And they provided us with so much of the information that we needed in order to do this investigation. So we're really appreciative to their cooperation with us throughout this. Next slide, please. So our first section introduces the paper and provides an executive summary. And I would say that the main takeaway that Disability Rights New Jersey wants to impart through this introduction is that this investigation and report is really through the lens of the 1999 Supreme Court decision, Olmstead versus LC, which held that the unjustified segregation and isolation of people with disabilities, particularly in institutions by the state, is discrimination. And that holding goes on to say that people should be served in the most integrated setting appropriate to the needs of the individual, and should allow people with disabilities to interact with non-disabled persons to the fullest extent possible. So this was really the bedrock for our report, for our investigation, and for our report. Everything that we did was firmly grounded in that Olmstead decision. And obviously, Disability Rights New Jersey, many, many years ago, brought Olmstead litigation with respect to the developmental centers here in New Jersey back in 2005 and 2008. And that led to a settlement that moved and found community placements for more than 600 residents of developmental centers who were identified as appropriate for those moves. And so what we really became concerned about, and this started before COVID, and I'll talk a little bit more about it in the next slide, and into COVID, is whether nursing homes had replaced developmental centers as the default institutional setting for people with intellectual and developmental disabilities in the absence of appropriate person-centered settings in the communities with services and supports. And I'm just going to pause for a second and say, Bren, there is a list, there you go. Thank you. The other thing that the introduction touches on is that we found that it's more than just the Americans with Disabilities Act and Olmstead. There are other federal laws that really can enhance a state's Olmstead strategy, and that New Jersey is either really off base or just not using them to the fullest extent of the law. And that was something that was really important for us to highlight throughout the report. And then the executive summary highlights the 3 findings and several of the recommendations, which we're going to be discussing as the slides go on. Next slide, Brent, please. So what we did was rooted in our authority under federal law to conduct a systemic investigation. Our authority is rooted in the Developmental Disabilities Assistance and Bill of Rights Act, and the report gives a little bit of our background and history. If you're not familiar, we were originally in state government. In 1994, we came out as a nonprofit, originally the New Jersey Protection and Advocacy, now Disability Rights New Jersey. And under that federal authority, and in particular the DD Act, we have the authority to conduct monitoring and investigations. And investigations focus on abuse and neglect if we have probable cause. And the federal definition of neglect includes a variety of types of neglect, but failure to have service plans and violation of legal rights and service plans that include discharge plans. And so that was the basis of our probable cause to believe that there was neglect to conduct this investigation. And as I said, it really started before COVID, where anecdotally through our monitoring, and we were hearing from a lot of our partners also, that people were just noticing that there seemed to be more people with intellectual and developmental disabilities in nursing homes. And that was perplexing because the federal law really doesn't contemplate people with IDD in nursing homes, absent very specific requirements. And so we all started asking questions. And one of the places we started asking questions was through the Medical Assistance and Advisory Council, or the MAC. And in 2019, and there is a typo here, I apologize, it says April 2019. The next one should say July 2019. The state provided us some figures on people with IDD in nursing homes. And you can see they're somewhere between the high 500s and the low 600s, both times they presented. And the difference in that data, to the best we understand it, is they rooted in DD indicators in coding that they use for people in institutions, and I think for billing purposes. And the difference is really that the lower numbers in April reflect people on managed long-term services and supports, and the slightly higher numbers, and again, apologies, it should say July of 2019, those slightly higher numbers include both people on managed long-term services and supports and people on fee-for-service. We did a lot of work in the spring of 2020 around COVID-19 and nursing homes. You can read about some of those efforts, in particular with Andover and Woodland in the report. But all of that sort of culminated in March and April of 2022 with launching our official investigation of people with IDD in nursing homes. We sent a letter using our investigatory authority to DDD, and in response, they gave us a list of 587 people living in nursing homes, which we reviewed. And when we took out some that just didn't have good addresses, or it didn't make sense, or they didn't have any address, and pediatrics, we came down to 525 individuals. I'll put a little asterisk to say the report touches a little bit on pediatric nursing homes and the people who are in them, mostly children, but also some young adults. And that is something that's still on our radar and is of serious concern, but not the subject of this report. Next slide. So what did we do? Here are some examples of what we did. We did site visits, we met people, we identified other residents, we collected information and documentation like face sheets and PASSR, pre-admission screening and resident review forms. I'll talk more about that in a second. We talked to guardians, stakeholders, and we did a lot of work conducting legal research and analyzing the law. Next slide, please. This slide is almost a repeat of the previous one, but it gives you a sample of some of the numbers: 71 nursing homes, meeting with 357 residents, talking to 21 private guardians, and lots of key stakeholders. Next slide. One other thing I want to say before I start this slide, I also need to point out that ours is not a scientific methodology. And so that this doesn't comport with whatever, social science requirements would be for a scientific study. So some of the conclusions that we draw are soft conclusions. They're things that are hinted at or suggested, but we can't say it with scientific certainty. So our first key finding is that the state just does not have complete, consistent, and accurate data regarding residents of nursing homes with intellectual and developmental disabilities. I'll walk you through that a little bit, and again, more in our next webinar that does a deep dive on this. And that the available data that we looked at, federal data, suggests that the state is substantially undercounting the actual numbers. And then this is sort of a sub point in this, but worthy, we think, of attention. And that is that there was a significant drop in the federal data between the second, during the second quarter of 2020. So from March of 2020 through June of 2020, which raises the question of what happened. I have a couple of examples that I just want to give here on some of the data that we reviewed. And again, I invite you to come to this will be presentation next week, I believe, our second webinar, where we'll be discussing this more in detail. But here's some examples of what we could draw. We saw that in 2019, I'm going to talk about the PASSAR in the next key finding, but that's a mechanism, a screening tool that identifies people who are looking to go into nursing homes who have either an intellectual or developmental disability or a mental health disability, which the federal law calls an MI. And so in 2019, 515 of these level 1 screens identified people to be referred to the Division of Developmental Disabilities as scoring as potentially positive, meaning potential IDD in that level 1 screen. And of those 515, 252 met the criteria for what's called exempted hospital discharge. And what that means is we don't have to do the full evaluation and determination, the level 2 screen on those people. They can just go into nursing homes for theoretically 30 days. And so we thought it was fair to draw a conclusion that if 515 people were referred and 252 of those 515, which is 48%, met this criteria, that they in fact entered the nursing home. We don't know that for certain, but we think that's a reasonable conclusion. I want to emphasize we have no idea if they stayed. We don't have no idea if they ever had the full level 2 evaluation and determination. DDD told us they did not track that, but looking at PASSARs, we could see that sometimes it was done. So we're not certain to what happened to those people, but we have a sense of how many likely went into nursing homes. One other thing before we go on to the next slide on this that I think is really important in this question about data. We don't have clear data about where these individuals came from. We have anecdotal data, but where they came from, we think, is a really critical question. And what we saw through meeting with people and talking to people and looking at these face sheets and looking at PASSAR forms is that many people came from acute hospital stays. And I think that's probably not unusual. A lot of people have an acute hospital stay and go into a nursing home for rehab. Behind that, what we could see is that many of these individuals came from either family homes or from group homes. That was the most prevalent information that we had. But again, this is really missing data that's just so critically important. Next slide. So in addition to the data we received from the Division of Developmental Disabilities, both the raw list and the data related to the pre-admission screening and resident review, we also looked at federal data that's publicly available from something called the MDS, or Minimum Data Set. And the Minimum Data Set is a screening and assessment tool that's used by nursing homes. The current version's from about 2010, and it's done upon admission, quarterly, yearly, and upon a change of condition. And then through the federal reporting, the nursing homes report back to the federal government, and this data is publicly available. And what's important to know about this MDS is that in 2010 and again in 2012, there were questions added that go directly to the PASSAR, the pre-admission screening and resident review. Again, I'm going to talk about that more in depth when I get to finding number 2, but the important thing for the purpose of this is to know that that's a tool that screens for people who are entering nursing homes who might have either an intellectual disability or a mental health disability that they call either SMI or MI. And these questions were added to the MDS and specifically prove that whether a resident has been identified to have an intellectual disability or a related condition, or, and if the answer is yes, specifically which do they have. Next slide. And so if you look in the report, there's a big table that gives all of this detailed information about the reporting on this federally available report. And here are some examples. I'm going to look first actually at the January to March of 2022. And you can see that the number that were reported for having an intellectual disability was 2,119. 2,119 is more than 525, right? I think we can all agree and see that pretty clearly. And so that's a concern. The other thing that this, and that's why we think they're substantially undercounting. And if you look at that whole report, you can see those numbers. And I put the next to most recent numbers here, which is still just shy of 2,000. In the third quarter, it dropped. We're not quite sure why. That's an anomaly compared to all the other numbers that are there, with the exception of this drop that you see here in the first set of numbers between January and March of 2020, when the number was 2,608 people were reported as being in New Jersey nursing homes with an intellectual disability. And that number by June had dropped to 2122, and a drop of 479 people. And the reason that that is significant is that is the first most deadly quarter of COVID-19 here in New Jersey's nursing homes. And so we think that that bears more research by the state of New Jersey. Where did those people go? We don't know that those people all died, but we're guessing that some percentage of them did. And it's really critical for the state to understand what happened there and how people with intellectual and developmental disabilities are affected in congregate settings, especially settings like nursing homes, when there's infectious disease outbreak, and whether or not they're cohorting and their infection control and all the other issues that go along with that. And the really devastating effects we had in New Jersey at the beginning of COVID. Next slide, please. So why do these findings and key finding number one matter around data and the amount of data and the accuracy of the data and the detail of the data? Well, first it matters because Olmstead requires a comprehensive, effectively working plan for ensuring that nursing home residents, by the way, that's all nursing home residents. We're focused here on residents with IDD, but it's really all nursing home residents, have community-based options. And how can you possibly have a plan if you don't know who the people are and where they are and what their needs are? So that's sort of key reason number one why this matters. The second is that in order to outreach to people, as well as to be in compliance with the federal pre-admission screening and resident review, that requires data about who people are and where they are. And so the state cannot both meet its PASSAR requirements under federal law and engage in meaningful outreach, for example, through the I Choose Home program, if it doesn't know who these people are and where these people are living. And then I already mentioned the drop in the second quarter. And then the last reason that this data is really important is to ensure equity in the delivery system, particularly around home and community-based services. In order to ensure equity, we have to be looking at what we're doing. We have to see if there's either explicit, I hope not, or implicit bias in the system as it stands now, and what we need to do as a state as we plan to ensure that we have an equitable system that provides access to home and community-based individuals. And for that, we need demographical information like age, race, ethnicity, so on and so forth. Next slide, please. We have recommendations that go along with key finding number one: across agency centralized data system, aggregate demographic information, a public dashboard, And there are quality monitoring and improvement measures that are part of the pre-admission screening and resident review. We put this recommendation here rather than the PASSR section because these can help with data collection. But this recommendation really could have gone in under either key finding. Next slide, please. Our second finding relates to the pre-admission screening and resident review. And honestly, this is really the meat of the paper. And here I'm going to talk about this at a sort of a slightly higher level, and we'll go more down into the weeds, into the depths of it. I think it's October 23rd when we're doing this presentation. So, but what we found was that New Jersey has significant failures when it comes to implementing this federal law correctly and robustly. And this has led to, and is continuing to lead to, the inappropriate institutionalization of people with intellectual and developmental disabilities in nursing homes rather than in home and community-based settings. And these failures, by the way, are long-standing. They go back decades, and there are many historical reasons for it. We'll talk about that more. You can read about it in the paper. But that the origins, kind of turning to the law on this, the origins of the PASSR are in the Nursing Home Reform Act in 1987. So it's a long-standing law. It applies to all Medicaid certified nursing homes in New Jersey, which is nearly every nursing home. And it requires the level 1 screen of every single person who seeks admission to the nursing home, regardless of their payer source. If they are identified as having an intellectual or developmental disability or mental health disability, then those individuals get referred for a more intense, person-centered, individualized assessment. And the purpose of this is first to evaluate all applicants for IDD and MI. The second is to offer the most appropriate setting with an emphasis on the least restrictive setting. And this is a place where our New Jersey system is not working. It really is just a one-way street for nearly everyone into the nursing home, with not a robust review of less restrictive settings. And then if somebody is going to go into a nursing home, it requires that that person receive all services, both the services that are typically provided in the nursing home, but also if the person is an individual with an intellectual or developmental disability or a mental health disability, that they receive what are called specialized services in the nursing home. Next slide. So what are specialized services? This is kind of a key thing. And I have on my piece of paper, which I'm not going to read to you, but you can read in the report, the formal federal regulation definition of specialized services. But I found this other definition in some of the technical assistance that was given by the federal government. And I think that this one is just a whole lot easier to understand and really gets to the heart of it. Specialized services are whatever disability-specific services a given PASSR individual uniquely needs. Uniquely needs is so key to these services, above what the nursing home provides under the standard reimbursement. So these are services that are developed through a person-centered, individualized process that tie into the unique needs of that individual. There is no one size fits all in specialized services. Next slide, please. So here's a little bit more about specialized services. They're provided to nursing home residents, primarily in the nursing home. I'm going to talk a little bit about how they can be provided in the community, but primarily they go to nursing home residents in the nursing home, residents who have IDD or a mental health disability. They are not, and I capitalize that, provided in an inpatient setting like a state psychiatric hospital or a developmental center. They are above and beyond the typical services provided to a person in a nursing home that's set forth in their comprehensive care plan. And I'll just divert for a second here to just be clear about this. The process that looks at individuals seeking nursing home admission first has to determine whether or not they need the services of a nursing facility at all, right? So if the person does not need the services of a nursing facility, then that's sort of the end of that inquiry. And then they should really be getting options counseling around home and community-based services. But if they need those services and they choose those services, right? They don't choose, because we can provide services that are equivalent to that in home and community-based settings. The trouble is our system can't meet all the needs of the people who might choose that. But if they need the services of a nursing home and choose them to receive their services in a nursing home, then those services, if they needed specialized services, would be included in their comprehensive care plan. And it can include what we call waiver-like specialized services to foster continuity of care. And so an example of that might be somebody who came from the community and was in a day program needs to go into the nursing home for a short-term stay because they have a very particular rehab need. And that is best met in an inpatient, in an nursing home setting. And yet they would benefit from still being in their day program. We could set up, New Jersey could set up, we haven't yet, waiver-like specialized services so that individual could still attend their day program while they were in the nursing home to help divert and transition back into the community. That is the continuity of care piece. Next slide. There is a process, it's complicated, it's laid out in the report. There's a preliminary screen, that's everybody who is seeking entry into a nursing home. There's also, sometimes it has to be done for people who are already in the nursing home. It's called a resident review then. If the person is somebody who is positive for an intellectual or developmental disability, they are referred to the Division of Developmental Disabilities, where a level 2 evaluation and determination is done. This is a very comprehensive, when done correctly, person-centered, individualized process that really looks at the needs and wants of the individual, the services and supports they need to be able to thrive, whether they ultimately choose to receive those services in a nursing home or in the community. And it's supposed to include what they would need in the community, in, written into the determination, even if those services aren't available in the community. It's one of the ways the state is supposed to identify gaps in the system. There are many exclusions that are allowed. They are optional under the federal law. And one of I'm jumping ahead a little bit here, but one of the things that we believe at Disability Rights New Jersey is that the state of New Jersey is overusing these exclusions to circumvent that individualized person-centered process in the evaluation and determination, because it allows them to skip parts of it. An exempted hospital discharge, I already mentioned, that's for somebody who's coming from an acute hospitalization and is going into a nursing home for no more than 30 days for that reason that they were in the hospital. And I think that that is, a common thing. Somebody needs either skilled nursing or rehabilitation for a short period of time after a hospitalization, but then they should be returning to the community. People are getting lost in that system. And the others are called categorical determinations, which is a confusing word. But these are reasons that the state does not have to do the fullness of the level 2. And it includes things like people are on respite. They're in the nursing home for a short period of time because of a situation that involved adult protective services. They have a terminal illness, or they have a serious physical illness. But again, we thought they were really being overused. An example, we found people who had a categorical determination for a hospice situation who the PASSR that found that, and so the fullness wasn't of the determination wasn't done more than 2 years ago, and that had not been revisited. Next slide, please. So how does New Jersey get the PASSAR process wrong? Well, they do it in two major ways. First is they don't meet basic compliance with the federal laws. And this relates to some definitions that they have embedded mostly in regulations around PASS, stands for pre-admission screening. And that's the process to determine that somebody is eligible for Medicaid, that they meet clinical eligibility criteria. Confused with the PASSAR requirements, which I've already said applies to everybody who's seeking to enter, regardless of their peer source. It is irrelevant if they are going to use Medicaid at some point. What matters is the facility Medicaid certified. More about that in the next webinar. And the definition of specialized services. This I am going to take 2 seconds on because it's so key. So the specialized services, as I've already mentioned, are services that nursing home residents receive, primarily in a nursing home. But in New Jersey, we define that backwards. We say that specialized services are specifically those services that a person cannot receive in a nursing home, that they can only receive them in an inpatient psychiatric hospital, by way of example, or a developmental center. Or New Jersey does say a home and community-based setting, which is close, but not quite right. And so that twisting of that definition has just had ramifications throughout this whole process. And we really just can't say enough that that is probably the main problem that needs to be changed in order to turn this system around so that it is working properly. The other factor about PASSAR that we're not doing well in New Jersey is to use it as part of our Olmstead strategy. The federal government calls it a powerful tool of an Olmstead strategy. And the reason we're failing to do this is, first of all, we over rely on those exclusions. I already mentioned that. We don't have any mechanism for specialized services in a nursing home because we define them wrong. See the bullet above. But if we were to define it correctly, we could use federal dollars to pay for specialized services. We do that through something called a state plan amendment. Other states have done it. And they could be typical specialized services for people who are in nursing homes for a long time and intend to stay there. But they could also be, more significantly, we believe, these waiver-like specialized services that can help people not lose their connection to the community if they come in for a short-term nursing home stay, so that they're more likely to successfully transition back after that 30 days, or for people who have been in there a long time to help them build the skills that they need to return to the community. So I gave the example already of a day program, but you could also have something, a specialized service that help people build independent living skills. And they could be working on this while they were in the nursing home as the transition process back to the community was in process, so that they had a greater success, likelihood of success upon transition. 2 other issues that bear mentioning here, housing and individual services remain a barrier. Housing, we just don't have enough of the housing that we need to serve people properly. And then the individualized, with the focus on the individualized person-centered services, ensuring they have what they need to successfully live in the community, is still lacking, especially for people who have complex needs. And person-centered practices are just missing throughout the entire system, including the PASSAR. Next slide, please. I am mindful of the time, and I am going to finish up in the next 4 minutes, so we have 15 minutes for questions. I was hoping for a little bit more than that. That's on me. Here are some recommendations related to the PASSAR. We have to revise it. We desperately need stakeholder input into this. First and foremost, people with disabilities and their families, and also advocates to get it right. Person-centered thinking has to be at the heart of this redo of our PASSAR system. We really have to look whether or not we want to keep these optional exclusions at all. We have to redefine specialized services. And once we do all this, we really have to do outreach and training for everyone in the system including hospital discharge planners, nursing homes, support coordinators, managed care organizations, everyone. Next slide, please. And our last finding was about self-determination and person-centered thinking. First and foremost, we want to emphasize that under the New Jersey Constitution, people have a right to self-determination, including expressing a preference about where they live. And the seminal case on that is the 1994 case, In Re MR. And that case made it clear that people with intellectual and developmental disabilities have this right, full stop, just like everybody else. People subject to guardianship may have it too, unless there's been a finding by a court on clear and convincing evidence that they do not. And number three, even when that's happened, there still has to be significant deference to the wishes and the expressed preference of the person with the disability. So that is really important and needs to permeate all aspects of our delivery system for long-term services and supports in New Jersey. We also have two significant federal laws, the federal person-centered planning rights embedded both in the nursing home regulations as of 2016 and in home and community-based services setting rule in 2014. A lot of people are familiar with the settings portion of that rule that only went into effect this past March, but the person-centered planning part of it has been in effect since 2014. Next slide, please. What are person-centered practices? Well, we're going to talk about that when we talk about this section, and I believe that is October 31st. I'm looking at Bren and Adrian. Great. Yep. Because this is really key to all of this. Everything we've said, really having person-centered practices and thinking that permeates our whole system is just so key. In terms of the federal rights, throughout these federal nursing home and home and community-based settings rule, person-centered practices are embedded as rights. And I really just want to emphasize that these are not just nice things to do, they are rights-based. And there are many aspects of those, and I'm being mindful of time, that we're really going to have to talk more to in that last webinar that we're going to do. But an example from the home and community-based settings rule that I think is just illustrative is that people have to lead the process, that the process has to involve informed consent, that there have to be options about housing, including community-based options and non-disability specific options, and all of the alternatives that are considered have to be put into the written plan. Next slide, please. And where does New Jersey get it wrong? Well, throughout. We need to really revise our nursing home regulations. We have to look at our 1115 waiver programs, and we have to look at our other laws to make sure we're really maximizing and conforming with the federal law. Next slide, please. Here are some recommendations related to our third finding, that we have to revisit person-centered planning rights throughout the system, really again with incredible stakeholder input. We have to focus on the service planning process to ensure that that really sees the person with the disability as the person who's leading that process. We should look at keeping people with DD on the DD waiver when they go into nursing homes for short stays. And we should have DD staff dedicated to working on nursing home transitions. Next slide, please. And then we have a couple of other recommendations that go more broadly to the system. And can we go to the next slide here, because I just want to focus on the Department of Health here, that the Department of Health has a role in this through the survey process related to people in nursing homes and residents' rights and person-centered planning. Residents' rights, we rank 47th in the country on citing deficiencies related to residents' rights, and we want to be in the top 10 on that, right? And so we need to work also with our Department of Health to really see that change. And I will stop there because I apologize, that did take longer than I had hoped. we're going to go to questions, and there's a Q code here where you can scan and see the report. But Bren, I am assuming there are some questions in the chat box.
There are some questions, and yes, if you haven't signed up for our next webinars that Gwen has mentioned throughout the presentation, you can scan the QR code or visit our website so that you can read the report, read it again maybe, and sign up for our other webinars. So we have the first question, Gwen, is about the concurring opinion by Justice Kennedy in Olmstead. And the quote is, or the question is, can you speak to the concurring opinion by Justice Kennedy, which warned, quote, "It would be unreasonable, it would be tragic then were the Americans with Disabilities Act of 1990 to be interpreted so that the state had some incentive for fear of litigation to drive those in need of medical care and treatment out of appropriate care into a setting with too little assistance and supervision."
So I'm not prepared to do a legal dissertation on the dissenting opinion right now, and I can't see the chat box, so I can't see everything that you just read, Bren. But I can say to you, without doubt, we at Disability Rights New Jersey says believe and will advocate that any home and community-based settings system has to meet needs. Full stop. There is no doubt about it. It cannot be a substandard system that doesn't meet needs. And then I'm also going to say this was really beyond the scope of this report, though I've been involved in a lot around nursing homes since COVID, including the governor's long-term care task force. And that's mentioned in the report. There will be a public report on that at some point in time. But I can say, broadly, I don't want to damn every nursing home in the state of New Jersey, because there are some good ones, but they are few and far between. So I hear what you're quoting from Justice Kennedy there, and I would challenge you that nursing homes are not, for the most part, meeting those very complex, individualized needs of people with intellectual and developmental disabilities. At least, we know that to be true, full stop. People are not receiving specialized services in nursing homes. So they are not receiving services that are uniquely tailored to their intellectual and developmental disability. So that would be my answer to that question.
Okay, Gwen, and then there is another question. Could you address how home and community-based settings, community services, which are the least restrictive environment, provide the following? Specifically, there was a doubling between 2019 and 2014 to almost 160,000 individuals where patients with IDD may spend weeks or even months, according to a Kaiser Health News report. Would it be fair to say that HCBS for those with violent rages, PICA, need for constant supervision, challenging behaviors is not being acknowledged? It says, while the report wasn't tasked with this issue specifically, I feel that the lack of HCBS services in the community puts families in dangerous situations.
So I think that's a version of the previous question, and I would say I'm not prepared to talk about the 2017 Kaiser report today. And this report, I hear this because I've heard this from other people too. This report was not a deep dive on our home and community-based services and settings in New Jersey, right? This was not something where we went in and looked at available group homes and services and supports throughout the state of New Jersey. This really focused on people in nursing homes. So what I can say is I think there's general agreement that the HCBS settings and individualized person-centered services and supports doesn't meet need. I think that we all agree on that. And we want to see that system for HCBS is bolstered, is improved with significant input from the most important stakeholders, which are people with disabilities, their families, and those of us who advocate in this space. And I also would say that we should be concerned about the amount of money through Medicaid that we're paying to provide services and supports in nursing homes, right? It's we didn't look at that question. We probably should have looked at that question, but it's phenomenal. I mean, when we were in Woodland, I did do quick math, which I don't have at my fingertips right now, about the third floor of Woodland, which had mostly people who had mental health disabilities. And for the sake of my memory, there were about 200 people on that floor. And when you did the math, it was like well over $1 million a month of Medicaid dollars going just to provide services for the people on that third floor. And I think it's a legitimate question for us to ask whether or not this is a prudent way to be spending our public dollars in these nursing homes.
And then it looks like the final in the chat is a recommendation for Amy Lutz's book, Chasing the Intact Mind, which seems to go towards some complex, the needs of some individuals with complex needs. But that is the rest of the questions in the chat. I don't know if anybody has any other questions. Please feel free to unmute yourself and ask if you do have anything else you'd like to talk about.
So, Bran, I quickly just looked at it while you were talking, and there is one that was directed at me, but I think is a question that is a good question for everyone. So let me just pull it up again. And the question is, waiver-like services, what are they? And specialized services, again, are services that are above the services typically provided in a nursing home, that are provided to nursing home residents, that meet their unique and individualized needs related to their intellectual or developmental disability. And waiver-like services, waiver refers to the fact that they're like a 1115 DD supports or MLTSS waiver service. They are like a service that somebody would receive in the community, and they are designed to either continue services that somebody was receiving in the community before they went into the nursing home. Again, somebody broke their hip, I'll just use that example, and they need to go into the nursing home for rehab. But some of the services that they were receiving when they were on the DD supports before, or the community care before they went into the nursing home, can be replicated and continued while they're in the nursing home, so that they increases the likelihood that they can transition back out quickly. Similarly, for people who have been there for a long time, it can be building block skills to help the person so that they're prepared to be back in the community. For example, independent living skills. And the report, in the interest of time, I'm not going to search for it in the report, but in the report, there are examples of the kinds of things other states have done around that. There's another question about whether or not the level 2 is related to the New Jersey CAT, and it is not. It is a separate evaluation and determination process that is done by the Division of Developmental Disabilities when they receive a level 1 screen that says somebody has is suspected of having an intellectual or developmental disability. But it is really comprehensive. It's supposed to be person-centered. It's supposed to involve an evaluation report and then a determination report that includes very specific things under the federal law, including what services and supports would be appropriate for the person, even if they're not available. And I think that kind of goes to some of the questions higher up. So that mechanism would be one of the ways that New Jersey could identify gaps in the system for people who have more complex needs that can't currently be met in the community. And then I think that's the only ones that are just this is a great question. Who is the person deciding if a person should be in a nursing home? That should be the person with the disability. Now, sometimes that person might have a legal guardian, for example, and then the legal guardian, but really that decision should be emanating from the person with the disability. Again, there is a role for legal guardianing there, and I talked a little bit about the case in Ray MR, and we'll talk about that more. I think the October 31st session, but it shouldn't be the evaluator. But I do think there's a lot of rubber stamping that goes on through using these exclusions.
And then Gwen, it looks like there's also a question about what education do nursing home administrators have around the screening, around the PASSAR process, and the assessment requirements that you spoke about. It seems like they're speaking a bit about their experience, that they're educating social services and administrators about what a PASSAR is. And so there's another question of if there's nowhere for them, so those administrators to get educated, could that possibly be a strategy, a recommendation?
Yeah, so that's a complicated question because I don't know that I want anybody educated right now on the PASSAR process that is inherently flawed and contrary to federal law, right? And so obviously they have to be because there will continue to be a PASSAR process in place, albeit a very broken one, while change is made. And I do want to say, I think that the Department of Human Services is open to change. I think that they want to get this right. I want to be clear about that. So what I can say to that is once the structural issues are addressed, the regulations and potentially the statute, so that New Jersey has a process in place that conforms with federal law, I think that all of these people are going to have to go through extensive training to get it right. And nursing homes also have to they're going to want to know that there's a mechanism to pay for specialized services, and that's through a state plan amendment, because those are services above that which is included in the regular rate. But I do want to say that specialized rehabilitative services, which are services for people with intellectual and developmental disabilities that don't rise to the level of specialized services, are already included in their rate. And I don't know that I've ever seen them in somebody's care plan. So there's already things that can happen based upon the state of the law as it is now. And I know we're down to the last minute, Brent. Are there any other questions?
There's one final question in the chat. When is the level 2 PASSAR done for someone who is in a subacute facility?
The level 2 should be done before the person goes into a facility, full stop. However, because I mentioned that exempted hospital discharge, that allows people to go in, and we could see those numbers, about 48% in the year example I gave. Many people go in under that 30-day exemption. They don't have to have the level 2 done. So then it is supposed to be done within 40 days of entering if they're going to end up staying in. We're not really clear that that is happening. And again, I don't know that the state is tracking that in any kind of rigorous way. Any other questions? People are recommending that we read books. Thank you for that. We actually are looking of doing a book club inside of Disability Rights New Jersey. This one will pass along to the people who are organizing that as maybe a good choice for us.
And no other questions in the chat, Gwen.
All right, great. Well, thank you all so much for joining us today. We really do appreciate it. We look forward to seeing some of you or all of you or more of you at the next 3 sessions where we'll dig in a little bit deeper. Thank you so much, everyone. Bye-bye now.